Welcome to Think Like a Pancreas, the podcast, where our goal is to keep you informed, inspired, and a little entertained on all things diabetes. The information contained in this program is based on the experience and opinions of the Integrated Diabetes Services clinical team. Please discuss any changes to your treatment plan with your personal healthcare provider before implementing.
Hello. Today, I'm super excited to be the host of our wonderful podcast, Think Like a Pancreas. And we're going to be discussing a really, really important topic today, kind of the whys and hows of screening for type 1 diabetes. And I'm Jennifer Smith. I'm Director of Lifestyle and Nutrition with Integrated Diabetes Services. And I'm glad to be joined by one of the people who knows an awful lot about screening for T1D, Gary Scheiner. Yay! Hi, Gary.
Hey, Jenny. I am thrilled to not have to host. I love being a guest because I don't have to remember or do anything special. I can just answer questions. My job's easy. You got the hard job today.
Not really. So, it's all good. I think a lot of people, we've had a lot more information about screening. I don't know, what would you say in the past 5 years? It's become much more visible and the benefits of it are being explained. But I think something behind it and the reason for screening really starts with the stages of developing type 1. And we know that at kind of the last stage is usually the diagnostic stage, right? Where we don't really know what was going on ahead of time. And now with screening, we have the ability to actually see, where are you? What stage could you possibly be? Tell us about the stages of screening. How are even the stages of developing type 1 that kind of go into maybe where you're thinking about screening your family member or child?
Yeah. It's analogous in many ways to doing checks for skin cancer because now when skin cancer is caught very early on, it's usually pretty easy to treat. There's special procedures that they just remove a few of the upper layers of skin in a local area, and it's gone. Yep. If it has a chance to permeate deeper and spread, it can be lethal, not just debilitating. And with type 1 diabetes, there are a number of antibodies that develop and show up in the bloodstream that are the precursor to developing symptomatic type 1 diabetes.
Right.
There's 3 stages to the development. The first stage is just the appearance of the antibodies. The blood sugar levels are perfectly normal. The pancreas still puts out a reasonable amount of insulin. So if you were to check your blood sugar after eating a box of Twinkies, it'll be perfectly normal. Or a box of Blueberry, whatever. So stage 1 is completely no symptoms. You'd never know type 1 was even in development if you didn't know the antibodies were present.
And thus, if you're a family that doesn't have type 1 at all, you wouldn't even think about screening, mainly because there would be no symptoms. It's almost like an underlying cold where you don't really have the symptoms yet. And then you finally do, and then you really feel like crud, right?
Yeah.
That's something that's sort of in the mix, but you really don't know until you do testing. So
yeah, or in the skin issue, it would be like having just a tiny freckle. I mean, there's nothing to worry about. It's normal. You get these all the time. Yeah. So stage 1, you're other than these antibodies being in your bloodstream, you're perfectly healthy and normal. Nothing unusual. So stage 2 is when the blood sugar levels start to decay a little bit. The pancreas is being attacked by the body's immune system, and you've lost some of the ability to produce insulin, but not enough for the blood sugars to go super high and cause the symptoms that we're used to seeing. So the only way to know you're at stage 2 is by doing blood sugar checks.
Sure.
I mean, whether it's a lab test, glucose tolerance test, or finger sticks, or an A1C, or even using a CGM, you'd have to be checking the blood sugar levels. It's in some way to know you're at stage 2. And typically at this stage, the fasting, the wake-up readings might just be a little above 100. The after-meal readings might be in the mid to high hundreds, but then they usually come back down again. So this is called a state of dysglycemia. The blood sugars are not quite normal. However, they're not so high that the symptoms show up. And that's stage 3. Stage 3 is when most people are diagnosed with type 1. They're already at stage 3. So you've gone from the point of a little freckle at stage 1 to kind of a larger odd-shaped spot on the skin at stage 2. At stage 3 is when you have full deep skin cancer at that point. But in this case, the pancreas now it can't keep up. It's unable to make nearly enough insulin anymore.
Mm-hmm.
In percentages, you probably lost at least 90% of your insulin production capacity by the time you get to stage 3.
The hard thing about that is you're comparing it to like the development of like a freckle into actual like a nasty skin cancer, is that at least skin cancer, there is something visible. Type 1 development, these stages really go unnoticed until you truly are at that stage 3 with
stage 3
symptoms, thirst, and going to the bathroom all the time. For little kids, it's typically like many wet diapers compared to what they normally would have, and like a thirst, or littles who are just irritable beyond anything that would be normal, and there's no comforting them. So I think that's, in fairness, it's like something that has literally no visible outward. You don't get green spots or like, purple hair in your ear.
Yeah. Until you hit stage 3, you have no idea there's a problem unless you've been checking your glucose levels. Sure. And as you said, stage 3, you start to urinate excessively, because when your blood sugars hit, are above 180 for periods of time, you start spilling sugar in the urine, and water is drawn with it, and you just pee your brains out. And I remember when I was diagnosed, that's what was happening. I couldn't drive 15 minutes without stopping my car and going to a rest stop somewhere and going to the bathroom.
100%.
You're thirsty, you're hungry. I had lost a lot of weight too, because I couldn't burn glucose for fuel anymore. It was just getting peed away.
Right.
What were your symptoms like when you were diagnosed?
No, I was going to say the same thing. I was, at an age where you don't really, like, you kind of are aware of paying attention to things, but not so much that you're even going to bring it to the attention of your parents. And I couldn't wait between my classes in school to run to the bubbler. Okay, well, I live in the Midwest, so it's a bubbler here.
Bubbler.
It's a water fountain everywhere else. But I couldn't wait between classes to actually run and get a drink before I got like into my next classroom, right? And then I also couldn't wait for it to end because I had to go to the bathroom. So it was like a decision. It was like bathroom stop at the water fountain, and then get to class. And then at lunchtime, I had hot lunch and would kind of encourage my friends to take more than one milk because I was so thirsty. And they were, happy friends, willing to do whatever. Jenny just likes milk. And so I would consume like 3 or 4 milk containers at lunch, more than I would even eat my food, because I was so thirsty. So, yeah. And then, at the point that I was diagnosed, it was the weekend of a dance recital. And I, again, was so thirsty. I was chugging like gigantic, just containers of water. I couldn't wait between our rehearsal sessions and everything. And then the morning of our actual dance recital, I woke up and my mom was like, there's clearly something wrong. Like, I was so dizzy, I was throwing up. And so she called peds and they sent us right to the emergency room. My blood sugar was 865.
You remember the number?
I remember the number. 100%. And my only perception of diabetes at that point in my life was my grandmother. My mom's mom had type 2. She had been on insulin for a long time, so I had already seen somebody taking insulin. But my very first question to the doctors was, does this mean I'm going to look like grandma? My grandma was a very large woman, also very tall, but just a very robust woman. And I thought that was what diabetes looked like. So I was very worried that I was going to look like grandma. I don't know. It's kind of a weird, kid perspective on things.
Yeah.
So
That's the typical onset of type 1 diabetes, is when all those symptoms show up.
Yeah.
And now we know more about how it develops. We can identify these, not symptoms, but these characteristics earlier.
Right.
And I think you mentioned earlier on, there hasn't been much attention given to screening until recently, because there wasn't much we could do about it.
Right.
But
well, and it kind of leads to like, who should be screened, right? Like, who really, especially in the case of, me, I have nobody else in my family who has type 1. I don't know about you, but we have a host of other autoimmune conditions. We have rheumatoid arthritis. We have a host of thyroid conditions, but no one else with type 1. So even at this day and age, I don't know that my parents would have said, hey, let's screen for type 1 diabetes, because there was no history of it in our family. Mm-hmm. But it kind of leads the question of like, before understanding even what it entails in terms of screening, like who should really be screened? And I think because of the odd prevalence of it being in families that have a history, as well as a lot of people who don't have a history, my personal and clinical is that everybody should just get screened. Like, I don't think it's a hard thing to just run a panel of antibodies and test.
Yeah, there is a push on in various medical associations to have everybody screened for antibodies that cause type 1 diabetes. And I should specify first what those antibodies are.
Yeah.
The most common one is called GAD65, GAD. There's also one called a zinc transporter 8 antibody. And then two others that are often found. One is called insulin autoantibodies, and another is called insulinoma antigen 2. So these all have acronyms that go along with them, but there's 4 primary antibodies that tend to cause the body's immune system to attack various aspects of the insulin production process. And I think of the insulin production process kind of like an assembly line where you're building a car. And if you pull one person or one department off that assembly line, you got cars rolling out that don't have wheels, don't have a steering wheel, whatever. It's not a functional car. Mm-hmm. If you remove one aspect of how insulin is produced or secreted, it's not going to work. So any of these antigens that are present can lead to it. So those are the 4. And you mentioned, it would be nice if everyone got screened. And given the state of how health policy is leaning in this country right now, it's very unlikely to happen.
Right.
So we're looking more at people who are at the highest risk. And if you have a first-degree blood relative with type 1 diabetes, your risk is 15 times higher to develop type 1 yourself. 15 times higher than in the general population. So it is absolutely worth getting screened. So that I would consider the prime population for screening. And you mentioned other autoimmune conditions, and that's a secondary. So if you don't have a first-degree family member with type 1, but you have other autoimmune conditions like hypothyroid, hyperthyroid, celiac, psoriasis, vitiligo, colitis, arthritis. There's a lot of other health conditions that are autoimmune, and autoimmune conditions tend to occur in packs.
People like have each other.
They do. They like to hang out together. So if you have one, you're likely to develop more. So that's a second population that's worth it. If you have a family member with type 1 and you also have an autoimmune condition, you're like a time bomb. You've got to get screened. They haven't calculated the actual risk, but it's really high. Mm-hmm. So we have a sense of who should be getting screened. Ideally, it would be cost effective, I think, for everyone to get screened, just so we know. And once someone screens, if it's a child and if they screen negative, they should probably get rechecked in the next few years. If it's an adult who screens negative, they generally don't need to be rechecked, again, unless they develop other autoimmune conditions.
Right.
So those are the populations we're looking at getting screened, and those are the antibodies they should get screened for.
Is there a beneficial age to consider screening relative to understanding, as you mentioning age, kids at some point test negative, they should probably at some point get tested again, right? With the consideration that, well, maybe they were negative and maybe they will show up, right? I think that's the hard and uneasy place to kind of sit mentally for many people, because you think, oh, great, the tests were negative, but is there still something that's going to almost like a switch that flips and all of a sudden they're positive, versus the adults who maybe there is a long family history of something and they get tested in their adulthood. I guess, what's the difference in age testing?
Yeah, with kids, the most common times for type 1 to develop is between 4 and 7, and again between about 10 and 12, early adolescence.
Yeah.
So even if you test negative prior to those ages, you should get screened again during those age groupings just to see if anything new has developed. But don't forget, more than half of type 1 diabetes is diagnosed in adults. So adults need to be just as wary of this as parents of children do. So adults who have a first degree relative, whether it's a child or a sibling or even a parent with type 1, should also be getting screened. You could be 48 years old, have no symptoms, but if you have a child with type 1 or your brother has type 1, you should get yourself screened. Because if those antibodies are present, now you need to be on the lookout. And we'll talk, there are a lot of things you can do to prevent it from developing.
Right. So if you do, I guess, have somebody in your family who has type 1, you now know about screening. What does screening involve? Who do you go to? How do you do it? What do you do with the information? Like, what are the steps involved in the actual screening process?
Sure.
Word from our sponsor. Byram Healthcare understands that managing diabetes isn't one size fits all. With a full range of CGMs, insulin pumps, and diabetes supplies from top brands, Byram makes it easy to get what you need, hassle-free, shipped right to your door. And Byram's team of experts helps navigate insurance so you can focus on living your best life. Ready for better diabetes care? Visit byramhealthcare.com/podcast or call 866-692-8024 and select option 3. And now, back to our program.
Yeah, there's two different ways people can get screened. One is just a blood test. So when you have your annual lab work done, when they check for cholesterol and all that other good stuff, just have them add on these, they call them islet antibody tests, the 4 antibodies that they look for. And most major labs, LabCorp, Quest, they all do this testing. Sure. So that's the most common way that it's done. But there is also the possibility of doing a home screening. You can order kits from an organization like TrialNet or Ask, ASK. They provide free home screenings that people can do. And it just involves doing a finger prick and following the instructions that come with the kit. You mail it in, you get the results a few weeks later. The home kits aren't quite as complete. They don't usually check all 4. They might check only 2 or 3, but it's a still relatively easy way to get it done. My thinking is if you're going to have blood drawn anyway, just add it to the list of things they're checking. There's no harm, no foul in doing that. It's no added inconvenience or anything like that.
I think it also begs if you're going to get it done through a lab, let's say your doctor is willing to order the tests for you. I think it's really important that doctor then know how to talk to you about what the results are, right? Because if you just have your regular primary care doctor, your regular pediatrician, sure, they can write the order, it gets covered by insurance and you get them done, but then you get these results, and having somebody can really talk to you and then direct you into the right next navigation point. I think that's very valuable.
Yeah. And it's rare to find a primary care provider, whether it's a pediatrician or internal medicine. They really don't know the nuances of this. And the best they can do for you is just agree to order the tests. And as patients, we just have to demand it. Say, I want this test done. Add it to my lab work.
Right.
But once you get tested, if you do test positive for antibodies, you should ask for a referral to a diabetes specialist.
Right.
They're the people
Endocrine.
that can help.
Yeah. And again, that might even be depending on where you are, your area. Endocrine practices are certainly shorthanded in terms of their time and ability. So it is something that's important to get in as soon as possible with positive results of any of these antibodies, because time is kind of a key in navigating whether you're positive or negative. So negative, as we talked about before, great. I was negative. I might have been a kid. I'll get it tested again at some point. I was an adult. I'm negative. Maybe or maybe not. Will I ever test again? Right?
Yeah. And a negative test has benefits. People are worried. They're concerned. Is my child, is my, my parent, are these people going to develop type 1? And as a person who's getting tested, you worry, am I going to get type 1? Testing negative for the antibodies, it's a tremendous weight off your shoulders because it's very unlikely it's going to develop. Not impossible, but it's very unlikely at that point.
Right.
So there's a lot of value in a negative screening just for peace of mind, if nothing else.
What about the benefits of getting the screening and the positive results? What do you think are the positives?
That's even more beneficial. Now, technically, a positive screening means you have 2 or more antibodies, not just one. If you have one and the titer is not real huge, it could go away on its own. Sometimes antibodies show up just temporarily, they fade. If you have 2 or more, the chances of you going on to develop type 1 are very, very high. And I'll share some of the stats with you about this because it's astounding. If you have 2 or more antibodies, I think the chances of you developing type 1 within the next 5 years is close to 50%. And in 15 years, it's approaching 100%. It's pretty much a done deal. It's not will it happen, it's just when is it going to happen? You're going to develop type 1. So what that does is it empowers you. So now it's like, all right, your dermatologist has detected this potentially problematic thing on your skin. We can biopsy it. We can see if it needs to be removed. And if so, it can be removed. In the diabetes case, there are a multitude of strategies that we can apply first to monitor ourselves and catch it when it's starting to progress to the next stage. Because, you caught it at stage 1. I mean, you're in a great position now. You can monitor your glucose, whether it's through finger sticks or using a CGM once in a while. And some people can even get over-the-counter CGMs and use them maybe once every few months just to see what your patterns look like. And, if you're starting to see, fasting blood sugars creeping north of 100, or you're seeing post-meal blood sugars that are up in the above 140 on a semi-regular basis, that means you're in stage 2. Things have progressed.
Mm-hmm.
And, whether you're at stage 1 or stage 2, there's a lot of lifestyle type things that a person can do. And at stage 2, there are medications that can actually be used to slow the progression. And you're going to love this since you're a dietitian and I know you're really into fitness, but the things we do from a lifestyle standpoint to delay the progression of diabetes are the same things we do for managing type 2 diabetes.
Right.
These are things that I call them beta cell bubble wrap strategies. These are things that ease the workload on our pancreas, that make our bodies more sensitive to insulin.
Mm-hmm.
It includes keeping our weight under control. Excess body fat causes insulin resistance, so losing some body fat helps.
And what adds to that? Exercise or movement in your day, right?
Yes,
I mean, that's a big piece of it.
It's the most powerful way to improve insulin sensitivity is physical activity. Mm-hmm. Cardio exercise in particular at this stage is really beneficial. Mm-hmm. Strength training helps, but not as much as the cardio exercise does. And from a food intake standpoint, just looking at the nature of one's diet, we don't have to avoid sugars. We don't have to avoid carbs. We want to just try to modify or moderate the amounts and not eat huge amounts of carbohydrates, and try to choose the kinds of carbs that are friendlier, that don't spike our blood sugar all at once, but are more slow and evenly digested and absorbed. Right. Your diet is full of those, Jenny. I know that.
I try most of the time, yes. Yeah. And I think something that is behind both of these pieces, these lifestyle changes, is the ability to get in with somebody who at this stage can direct you for how to make these changes, right? It's not the rip-off page from just a doctor telling you to go take a walk and stop eating sugar or putting it in your coffee, right? It is really some very strategic and very individualized. There's value to seeking out working with an educator even at this stage, because they could be somebody who helps you to preserve these beta cells even more, sort of better bubble wrap, right? Not the generic version, but the actual brand name version of the bubble wrap. And if if you want to get the most bang out of this time period of delay, then working with somebody who can really individualize and say, well, goodness, you could stop drinking juice and have water in the morning for breakfast, right? You could change this up slightly. You could make these adjustments to things. Even
oatmeal instead of blueberry.
There you go. Oatmeal instead of blueberry or frankenberry or Count Chocula, right? Exactly. I mean, there are little strategic changes that don't have to be major in terms of the person's changes.
Yeah, I learned that sweet potatoes are so much slower than white potatoes at raising blood sugar. That's a better choice.
And even the method of preparation of food. I mean, you can get into the nitty gritty of discussion truly, but it is food and activity are huge in terms of preservation and proper body metabolic response. The better that you can do with real, whole, unprocessed food at this stage, the more potential preservation time you're going to have.
And a lot of the things we teach people with type 2 to manage better and avoid further loss of their own beta cells, things like managing stress levels, because stress hormones kind of block insulin's actions. They work against it.
Right.
Getting quality sleep can make a big difference as well. We produce cortisol, these other stress hormones, when we don't sleep well. And avoiding medications like steroid meds, prednisone, cortisone, whenever possible.
If possible.
Those create tremendous insulin resistance. So, just these kind of lifestyle choices can make an enormous difference in terms of, how long is it going to take for the type 1 diabetes to progress and develop into symptomatic type 1 that's going to require intensive insulin therapy. And in some cases, it's even possible some people avoid it entirely. It never develops. So there is that opportunity as well.
At this stage, is there ever a consideration of using even a minor amount of background, what we refer to as basal long-acting insulin, for some people just to take a little of the stress off of the beta cells and preserve them longer too?
That was studied decades ago. They thought that, bringing in the cavalry, let's bring some fresh outside insulin in. They actually didn't find that to help.
It
didn't seem to slow the progression.
Okay.
But there are other medications now they found that can. These are medications that are sometimes used in people who receive organ transplants. They help to suppress the immune system so that the beta cells aren't being attacked so vociferously. It eases up on the attack. And one of them, it's called Tzield. Generic is called teplizumab. That's approved for use in stage 2 of type 1 diabetes. And the pivotal trials that were run on that showed about a 2.5-year average delay in the development of type 1 from taking this medication. It's not as strong as the doses and length that are used for people who receive organ transplants. People get organ transplants, they have to take high doses of this stuff for a lifetime. Sure. In this case, the Tzield's only administered for 2 weeks. It's at a relatively low dose, but it's still that alone had the power to delay by an average of 2.5 years the progression to stage 3 type 1 diabetes.
Has that been extended at all now Tzield has been available now for a bit of time. Has that 2.5 years, have they shown actual progression for longer preservation and sort of delay in diagnosis?
It will. They are doing ongoing studies on people who are involved in the research. They most likely will find a longer extension type delay. But what they also have done is they've studied it at stage 3. They studied it. People, you're at stage 3, you're peeing, you're drinking, etc. Let's do it now and see what happens. And the published data is very favorable. It does preserve insulin production capability by the pancreas. It's not yet approved for use in stage 3. That's still coming, but the progress is good.
And that's wonderful progress, mainly because if even diagnosis is made, the potential of preservation means not as difficult to navigate, not as much insulin is needed, more potential background assistance from those beta cells. I mean, there's even the long-term, we always talk about complications and the prevention of complications once you have diabetes. But my understanding is also that the better underlying beta reserve. It's a reason that people who are diagnosed as an adult often tend, with good management, to not be as, I guess, there's not as much potential for complications, right?
That's right. And Jenny, we both see, occasionally we get lucky and get a patient who's still in that honeymoon phase of their diabetes, and their pancreas still produces even just a little bit of insulin. It makes their glucose management 1,000 times easier.
It does.
They can usually just take a long-acting insulin at a low dose, maybe an occasional meal dose, but their blood sugars barely budge. They stay within target zones pretty consistently without a whole lot of work they have to do. That's the honeymoon. It's a beautiful time. I didn't get a honeymoon. When I was diagnosed, I had gone the entire summer just peeing and drinking and eating and losing weight. My beta cells were dead on arrival. And it was a miracle I was not in ketoacidosis, because most people are in DKA.
Oh, I was.
When they go that long at diagnosis. Yeah. And when you get to that point, you don't have much beta cell function left anymore. And I wish someone could have told me months or years before that I had the antibodies and this could have been happening, because I could have had that prolonged honeymoon. And what happens is, if people are diagnosed at stage 3 and they still have a decent amount of insulin production in their body, that honeymoon can go on for years. You've seen cases where it goes on almost indefinitely. They just never get past the honeymoon. I mean, rarely that happens. No, you marry somebody and the honeymoon just lasts forever. But yeah, that's not usually the case. Usually, you get a week, a month, maybe. Hey, everything's wonderful. And then the reality of living with someone 24/7 kicks in. But there are people who have that honeymoon that just goes on and on and on. And that's one of the benefits of early detection. You catch it early. You do the things to keep the beta cells functioning as long as possible. And there's enough of them still functioning, even when you get to stage 3, that they keep functioning. And you have that easier management, that nice glucose control that can go on for years. And as you said, not only is life easier, but you've just sharply reduced your risk for long-term complications.
Yeah. No, in terms of the positive sort of results, I think there's also the ability to prepare for what you know. Like, it gives you educational opportunities early on to dig for information, to look for even studies, to look for things to be able to do, and to prepare family members to be able to educate a little bit better. And if it's for a child, getting them in on that education early and the idea of what this might look like. It's just it's almost like an easing your way into, rather than a very rapid emergent room kind of diagnosis where, oh gosh, here, we're throwing this all at you and you had no idea.
Yeah. The incidence of DKA in people who got screened for antibodies is minimal. It's very, very low. It's close to 50% in people who didn't get screened. And DKA is no laughing matter. It can be fatal. And by that point, you've destroyed almost all your beta cell mass. You're not going to have much of a honeymoon at that point, if any. Like me, I had none whatsoever. So yeah, the screening is extremely valuable.
It certainly sounds like it's a good reason to screen. I know that I talk about it with all of the clients that I have the opportunity to work with, within the integrated diabetes practice. Even a number of families who've had other children in their family screened. And, I think there's also something to not only screening and some of the therapies like the Tzield that you talked about. Not everything works for everybody, right? So there are these positive things that could come from screening, but there's also the consideration that I've had one family who I worked with for their younger child, and their older kids also got screened. One who was completely negative, the other one who had antibodies, did the Tzield, and it really didn't do anything in the preservation long term. But what I do see as a difference in between those two kiddos was the one that did do the Tzield, despite not having a delay in type 1 diabetes true development, that's stage 3. The management for that child is, as we talked about, it is so much easier than it is for the younger child in that family. So much easier. And I expect that it is because the Tzield had an impact on the betas that were there would be my expectation, and just gives an easier overall navigation. So again, all these therapies, they're not 100% perfect to everybody, but yeah.
And I recognize it's an emotional decision.
It is.
To have a blood relative screened, or if you have a blood relative, to get yourself screened. It's an emotional decision, because you're finding out about a potential serious health issue.
Right.
But that's why I like to put it in that skin cancer screening term. If you get screened and you're negative, great, relax, enjoy yourself.
Right.
If you do screen positive, you can be proactive at that point. You're not sticking your head in the sand.
Right.
You can do things to keep yourself healthy and vibrant for a long, long time.
Even if it's just the lifestyle stuff without any medical true intervention, right?
Or just monitoring yourself once in a while so you catch it before it's at stage.
Yeah. You've got kiddos. Did you and your wife decide to do any? They're adult now, I know, but did you when they were younger, or have they decided now as more adults on their own decision-making tree? Did they decide to do anything?
Well, when they were young enough that I had some degree of control over them, which I don't anymore, no, I didn't, because I felt, well, what do I want to know for? There's nothing I can do about it, even if they test positive. And when they finally grew up and now they're all in their 20s and I have no control over them, now I want them to be screened. So I provided them all with the information to get screened. I highly recommend it, as in, like, I'm cutting you out of the will if you don't get screened, that sort of thing. And it's up to them now. I can't force them to, but I strongly encourage them to get themselves screened.
Yeah. My kiddos were also, as I said before, we're probably a few years, 3 to 5 years into really having some viable options from what has come out of the potential for screening. So years ago, when they were younger, we decided to not screen, right? Now we do very regular, just finger sticks. My kids actually like doing it. They like to wait for their number to pop up. Being an educator and knowing the signs and symptoms very well, we pay very close attention to any changes or anything like that. But because, it is actually a conversation that we've had more recently, is at this stage, there are some things that we could potentially do. My kids are old enough for some of these things. So it is in the discussion of now should we? And they're also of the age of understanding what that might mean, and to be able to have that discussion and even changing. As a dietitian, I'm kind of like the mom who doesn't let them do a lot of the things that their friends get to do. Like, they don't get candy in their lunch boxes, and they don't get a treat after dinner just because it's after dinner and it's time for dessert or whatever. I'm that mom, and I will entirely 100% own that it's keeping my kids healthy. But in understanding, if we did do testing, the idea that they would need to understand what that means, and then result dependent, what that would mean for some of those lifestyle changes that we may need to make. My kids are active. I don't think I could make them any more active than they actually are. Know how active my kids are.
I played soccer with your kids last weekend, and man, was I sore afterwards. They ran me ragged.
Yeah, they're just athletic, both of them in their own way. And food, we do a really great job outside of the birthday party or going on vacation where things get a little bit off. In general, that part is already really well navigated. So again, from a testing standpoint, it's now there are things. So now there's a bigger discussion for actually going forward with that. Whereas before I didn't think
that. I respect that entirely. Now, this is a very individual, personal type of a decision to make. I'm glad to have this opportunity so that people who listen can make an informed decision.
Absolutely.
I want to get around the misinformation that might be out there. Let people know. We're letting people know about the latest research, the actual science behind this. There is a lot of potential value to screening. And I think we went through pretty clearly. And I encourage everybody to consider it and make an informed decision that's in your best interest.
No, 100% agreed. I think it was great to go over everything, all of the available options, what the testing, the screening kind of looks like, because I think even with it being very easy, so to speak, to access at this point, understanding what would the screening process look like, and then what can I do about it? Who do I need to address if the results are positive? What would that mean? And the individual nature of deciding, it is and should be a family discussion decision. No one person in that family situation should really make the decision, because then they may have to house that decision themselves. And that can be very difficult for one individual. So it has to be an agreed upon all around decision to go forward and understand what you're going to do.
The support out there is not great. I admit that. I mentioned primary care. They know very little about this. And even in endocrinology care, there's not a lot that really understand this whole process and testing and how to mitigate the progression, et cetera. So I have a batch of clients now who are family members of our patients who don't have type 1, at least symptomatic type 1 yet. But they tested positive for antibodies. So we're teaching them all they can do to slow the progress. So folks can reach out to us if they have questions or if they want assistance. They can contact Integrated Diabetes, and we'll be happy to work with them.
That's what we are absolutely here for. So thank you so much. What a really important topic to discuss and be able to put out there. I mean, we're just the beginning of October, but National Diabetes Month is November, right? So hopefully more information, certainly will help within that whole month of not celebrating, but really highlighting diabetes navigation. This is fantastic. Again, if you are looking for more information, more hand-holding through this whole process of testing, understanding, maybe some life changes, please let us know. Integrated Diabetes Services has a host of clinicians that very knowledgeable, can absolutely and very happily help you on your journey.
Thanks for tuning in to Think Like a Pancreas, the podcast. If you enjoyed today's episode, don't forget to like, follow, or subscribe on your favorite podcast app. Think Like a Pancreas, the podcast is brought to you by Integrated Diabetes Services, where experience meets expertise, passion meets compassion, and diabetes care is personal because we live it too. Our team of clinicians, all living with type 1 diabetes, understands the challenges firsthand. We're here to help no matter where you are in the world. From glucose management to self-care strategies, the latest tech, sports and exercise, weight loss, type 1 pregnancy, and emotional well-being, we've got you covered. We offer consultations in English and Spanish via phone, video chat, email, and text. Want to learn more? Visit integrateddiabetes.com or email info@integrateddiabetes.com to schedule a consultation. On behalf of Think Like a Pancreas, the podcast, I'm Gary Scheiner, wishing you a fantastic week ahead. And don't forget to think like a pancreas.